So this is Dr. Manasa from OBG and Obstetrics and Gynae department. So from Siddhartha Medical College, T. Begur. So today I am going to present a case of postmenopausal lady who comes with the ovarian mass. So how does she present? How do you come to the conclusions? What are the differentials you look into? And what are the clinical findings which is more going towards the diagnosis? So these things we'll try to come out through this simple case history taking. Okay, so here are the patient details. So unless until you have a consent of the patient, then only you can give the name and details. Otherwise always you can address it as Mrs. X. So who has her age is very important because she's been addressed as a postmenopausal lady, and from which place she is coming and date of admission, and all these are the basic details of the patient which has to be mentioned. So next, coming to the presenting complaints, always it should be in the hierarchy wise. What is the main complaint she is of? Is there any issue now presently? So main issue was for her, there was a complaint of pain abdomen since 2 to 3 weeks. So that was a main concern for her to come. So along with that, there was associated complaints of mass per abdomen since she started noticing since 2 weeks. And then she had a complaint of mass per vagina, which was almost like 10 to 12 years. Okay, so the actual concern for her was the pain abdomen and the mass which she started observing from 2 to 3 weeks. But there was a chronic history of mass per vagina which was not so much concern to her, but along with these complaints she is telling it to us now. Okay, so if you try to elaborate the history, so she was normal, well and good 2 to 3 weeks back, where she suddenly started experiencing pain abdomen, and which was more in the light lower quadrant and insidious onset, which was not sudden. So initially it was low intensity where it started to aggravate as the days passed on, and which was progressive, which was associated with loss of appetite, and there was a vague bloating sensation and early satiety. Okay, so and along with that she had a mass per abdomen which she's been noticing since 2 to 3 weeks, which was gradually progressive. Understood? So there was also, as I mentioned in the complaints, there is a chronic history of mass per vagina, and which is increases on cough and Valsalva. And then if you have to rule out based on these complaints, you are now dealing with a mass per abdomen who is a postmenopausal lady who comes to you. Okay, and she has the GI symptoms associated. So if you want to rule out what it can be, you're trying to tell there was a complaint of loss of weight. So you're suspecting if the mass is reducing her appetite. So then there was no complaints of acute pain or dyspepsia. It's a chronic pain, dull aching. So this is not, she doesn't give any episodes of sudden acute pain. And there was no bowel or bladder complaints, no complaints of bleeding per vaginum, or there was no issue of any hormone replacement therapy. We're trying to rule out to centralize our diagnosis. Okay, so now if you have to elaborate, these are the anticipated negative histories which you can ask prevailing to the case to know why was a mass per abdomen she presented and what are the issues she is dealing with. So now if you come to her regular menstrual history, she is already postmenopausal and earlier cycles were regular, well and good. And if you come to the obstetric history previous, she has been married since 46 years, and that consanguinity, yes, you have to mention. And she has a parity of para 6 living 1, dead 5. There was 2 male and 4 female kids, and there were 5 deaths which has happened, and the causes were unknown. So if you have the detailing about it, yes, sure, you can mention, but prevailing to this case, there was no much details why the death happened. So these things, whatever you get the information, you can detail it like this. So now past history, the only past history was she was a known hypertensive with irregular treatment, not on a regular basis treatment. Okay, so if you come to her family history, there is some correlation where her elder sister also suffered with lump in the neck who underwent cancer treatment in Kidwai hospital. That further details are unknown, and but she is alive and healthy as of now. And if you come to a younger sister, there is history of carcinoma of cervix. That is what they tell, but details are not known, but she is not alive. Okay, so whatever they tell to you in the patient's language, you can write it over here. So coming to personal history, these are the basic things you should ask: the diet, appetite, bowel and bladder, how is the sleep, is it the condition has caused any changes within a day-to-day personal diet, sleep and bowel bladder activities, whatever is there, that you have to mention. Okay, and earlier how was it before, prior to this. Now, after the detailed history taking, now we come to the general physical examination where we have to examine to conclude the conclusions. So, what is the direct statement you start? Patient is conscious, cooperative, well oriented with time, place, person. So, lean, built and nourished. So, based you can gauge the patient's build and comment it by telling obese built, lean built or average built. So based on whatever you find the morphology, you can just give a vague term. So for me, it was a lean built and nourished lady, and she was conscious cooperative. Obviously, if she's telling the history, she'll be conscious cooperative, well oriented with time, place, person. Okay, these are the, so you have to get the exact build. Always the BMI. In any female patient, BMI you have to check. So there is a formula where which you be known. So you calculate the overall BMI based on her weight and height, and you comment it, and you can grade whether she's lean built, average, moderate BMI or obese based on the BMI recording. Okay, so now we have to check for the pallor, ictus, cyanosis, clubbing, lymphadenopathy, breast and thyroid. So only findings we got from the oral examination was she was pallor. Okay. Now coming to the further vitals where we have to check the pulse, BP, respiratory rate and temperature. So the vitals were also examined here. The only thing which was on a high recording was the BP, which was around 170, 100. Already I mentioned in the past history, she is a known case of hypertensive which was on, she was on irregular treatment. So that is why when she came, her BP was 170 and 100. So CNS, there was no focal or abnormalities. Higher mental function was well and good. Now coming to systemic examination per se, a CVS had no issues. S1, S2 was heard, and respiratory normal vesicular breath sounds were heard. Coming to our specialty per se, we need the per abdomen, PV and per speculum findings. So the per abdomen, when we examined, there was a irregular hard mass approx of 24 week size. Okay. So the origin, we thought it was a query pelvic mass which was fixed, hard in consistency and hard in consistency. And coming to per speculum examination, there was a third degree UV prolapse with grade 2 cystocele, enterocele, which was reducible with keratinization. So already she had a chronic history of prolapse. So obviously these were the findings which was concluded on per speculum examination. Now coming to the per vaginal examination, so there was a irregular hard mass which was 24 week size, which was separately felt from the uterus, and both the fornishing on both the sides, fullness was present. Okay, fullness was felt. So now based on the examination and history and all the clinical findings, the provisional diagnosis which was given is a postmenopausal woman with bilateral ovarian mass with grade 3, UV prolapse, grade 2 cystocele with enterocele with bilateral moderate hydroureteronephrosis with known case of hypertension for further management. Okay, this was the overall provisional diagnosis which was given. So coming to further investigations. So coming to the investigation, we did a basic pre-op blood workup. Where we have to proceed further, we need a basic pre-op blood investigations which was being done. Everything were within the normal limits, and we wanted to rule out if mass per abdomen suspecting a adnexal mass. Based on the clinical examination, we got a CA-125 tumor markers done, which was raised in thousands, and chest X-ray, ECG echo was within the normal limits. So this was a basic blood workup. Whatever blood examinations we have done, I have listed here. All were within the normal limits. Like basically we get a CBC done, platelets, we need total count, sugars, creat, electrolytes, thyroid, serology, and urine routine. So all this in briefly I have mentioned. So this was the report, the CA-125 lab report, which I have scanned and pasted here. So it was in 1133. And next was the further, always in any ovarian mass, if you are suspecting a ovarian mass like adnexal mass, always the best of finding what you can do in that too in a postmenopausal, get a simple ultrasound done to know where is the mass arising, whether it's a uterine mass or adnexal mass. And then it gives a vague idea. No, actually telling than vague, it gives almost a precise idea what is the mass as. And then you can further confirm it by doing a tumor marker. Most commonly done is CA-125 for all the epithelial ovarian masses. Okay, so we got a scan done. So this is the copy of the scan, and coming to the proper impression, there was a large abdominopelvic solid cystic mass which was extending from pelvis. So it also tells it was extending from pelvis to the umbilicus, which is bilateral. So almost size they are measuring 25, 12 into 15 centimeter, quite a huge mass. Okay, and so over uterus is separately measured. So from that we can conclude it's a ovarian mass. So this was other ultrasound. Now we got further evaluated by doing a MRI pelvis to know what the extent of tumor and was it extending to surrounding organs. So these are the findings where you can see there was a solid cystic mass 11 into 16 into 20 centimeter. Mass was not seen separately from the ovaries, it was seen compressing the uterus. So pressure effect was there on the uterus, and it was causing mass effect on the bladder also and adjoining bowel loops. So that effect is there, okay, and pelvic mesentery is also been, fat stranding is seen, and there is also mass effect. Due to this there is bilateral hydroureteronephrosis due to the pressure on both the ureter because of the size of the mass. And there is multiple enlarged para-aortic bilateral external internal iliac lymph nodes noted. So here it MRI itself tells the lymph nodes were involved, largest is 2.5 to 2 centimeter. So this is the findings. So now coming to the course, what we did, she was admitted for so and so complaints, we got a pre-op workup done, cross-reference were given to the cardiology, orthopedic and anesthetist to get the fitness. So we proceeded to do a cytoreductive surgery. The ovarian mass postmenopausal lady, based on whatever findings we have got, we thought appropriate will be the cytoreductive surgery, debulking procedure. So this was done, and then she was taken to the surgery on 17th of June 2025. So what are the operative details? So this is a laparotomy with excision of right and left ovarian mass. It's a bilateral ovarian mass. Both excision we have done along with adhesiolysis, release, total abdominal hysterectomy, infracolectomy and appendicectomy, pelvic and para-aortic lymphadenectomy, and there was a rent in the sigmoid colon during the procedure, and that was also repaired under GA. So these are the operating details. So I'll just tell you the intra-op, what were the intra-op findings we got as soon as we got a vertical incision done on the abdomen. So as soon as we removed, we could find ascitic fluid of approx 200 ml present in the abdomen, okay, and then in the gutters there was a right ovarian tumor which was approx 20 into 15 centimeter, which was both solid and cystic consistency, on look also, on touch also. And it was adherent to small intestine, and the same counterpart ovarian tumor there was on the left side, which was almost 20 into 20, and it was also same of solid and cystic component, which is firmly adherent to retroperitoneal structures. So one was it was adhered to left ureter, causing hydroureter thick adhesions to sigmoid colon, and there were few lymph nodes of pelvic lymph nodes query metastatic. It was just 1 into 1 centimeter, okay, and there were few para-aortic lymph nodes which was 3 into 2 centimeter. It was quite a big enlargement, and it was a query metastatic. Appendix appeared normal and uterus was grossly normal. So the procedure went on where we had to release the adhesions of the right ovary from its surrounding structures, from the bowels, and whatever rent has been made from blunt and sharp dissection, same thing was done from the left ovary side also. The blunt and sharp dissection was done and all the adhesions was released. During this process there was a rent in the sigmoid colon which was up to 5 centimeter, which was repaired then and there, and whatever tumor, how much ever it was possible, it was curated using Sims curate, ball, burnt by ball cautery. Okay, so this is the extent made it accessible to optimal cytoreduction, and then we further proceeded with hysterectomy, vault closure done and fixed. So then we had to remove pelvic lymph nodes, appendicectomy was done, and whatever the lymph node which was more than 1 centimeter para-aortic side we had to remove, which was less than 1 centimeter, we left it there only. And then after all the procedure, infracolectomy and appendicectomy it was proceeded, and then drain was kept, hemostasis achieved, and abdominal closure after knowing all the MOP counts were clear. So these are the intra-op findings which you can see as soon as we are opened. This was the tumor, and this was the ureter. As soon as the pressure was released, the compression reduced, and this is a para-aortic lymph node around the aorta which was seen, almost quite big, 3 into 2. So this is a cut specimen once it was retrieved, and these are the specimens which was removed at the end of the surgery. So this is the management, how we proceeded with this case. At lastly, I want to tell about a peritoneal cancer index. So this is basically a scoring given for all the abdominal tumors or any peritoneal cancers, where we divide the abdomen into quadrants, okay, into 13 quadrants, and we see how in those quadrants where does the lump occupy, the cancer tumor occupies, and we also gives measurement. So 2 to 3, less than 3, more than 5. Based on that, we give a scoring system. So according to our case, it should be within 0 to 39, and score is 0 to 3 based on the tumor size. So our score was, so this is a small tabular column how we divide into 13 regions, and the lesion, L0 is no tumor, tumor up to 0.5, 5 centimeter, LS3 is more than 5. Okay, based on all these findings, we have scored our tumor as 20. So this is how we manage the postmenopausal lady who came with mass per abdomen. And later on, after the histopath findings, further follow-up was given to her, but she refused the further treatment, where she was referred to IO center, the cancer center, for the further treatment and follow-up. So this is the end of the case presentation. Okay, thank you.